Hi, so today I'll be talking about coronary circulation and the corresponding ECG representation of the same. So first of all, we have to talk about the two main arteries which form the entire coronary circulation, which is the right coronary artery and the left coronary artery, or the LMC, that is the left main coronary artery. So the right coronary artery arises from something called as the aortic sinus. Both of them actually arise from something called as the aortic sinus of Valsalva, right? Aortic sinuses of Valsalva, which are present at the root of the aorta. The right coronary artery arises from the anterior aortic sinus of Valsalva, and the left coronary artery arises from the left posterior aortic sinus of the Valsalva. The right posterior aortic sinus of Valsalva is a non-coronary cusp and does not lead to anything. So now talking of the two main arteries, let's talk of the left side first. So after rising from the aortic sinus, we have the LMCA, which has a very short course, and then it bifurcates into the LAD and the LCX. The LAD is the left anterior descending branch. The left anterior descending branch then further goes down and gives branches, that is the diagonal branches D1, D2, D3, and the septal branches are the septal perforators. Along with that, the LCX circumflexes around and gives obtuse marginal branches that are the OM1, OM2, and OM3, right? Along with that, sometimes it happens that the LMCA doesn't bifurcate, rather trifurcates, and this another new branch arising out of the LMCA is termed as the RI, that is the ramus intermedius. Next, we move to the right side of the heart, from where the RCA arises from the anterior aortic sinus of Valsalva, right? So the RCA gives up a few branches initially, which are the SA nodal branch, the right conus artery, the atrial branch, and the right anterior ventricular branch. After that, it goes on to give the right marginal artery. Along with that, the RCA goes down and circumflexes around, okay? And it circumflexes around, and at a point in the posterior wall called as the crux of the heart, or the crux cordis, it divides into PDA, or the posterior descending artery, which is responsible for supplying the posterior wall, okay, which and the posterior 1/3 of the septum as well. And from the cusp is another artery which comes out is the AV nodal artery, okay. So we will talk of the clinical relevance of this very soon. So here we have completed all the arteries. Now let's talk of what walls do these arteries give their supply off to, and what is the ECG lead representation of the same. So talking of the anterior wall, the V1 to V4 leads represent the anterior wall, and it is supplied primarily by the left anterior descending artery. Mainly supplies the anterior 2/3 of the septum, the apex, and obviously the anterior wall. The anterior wall is supplied mainly by the diagonal branches, and the anterior 2/3 of the septum is supplied by the septal perforators, which we earlier talked about, okay. Next, we talk of the lateral wall. The lateral wall is represented by leads 1, AVL, V5, and V6, and it is obviously supplied by the LCX, or the left circumflex artery, and primarily supplied by the obtuse marginal artery, that is the OM1, 2, and 3. Often, sometimes the D1, D2, D3 also supply it. Next, we talk of the inferior wall, which is a very famous wall. First of all, the ECG representation of it is the lead 2, 3, and AVF, and it is supplied by the RCA or the PDA. Now, in left dominant circulation, the PDA arises out of RCA in about 85 to 80% of the cases, and that's, as I said, left dominant circulation, and that supplies PDA supplies the inferior wall. And if PDA is supplying the inferior wall, but it's a left dominant circulation, then the PDA doesn't arise out of the RCA. Obviously, it arises out of the left circumflex artery. Okay. Another nuance over here is almost anything, whatever is supplying the inferior wall also supplies the posterior wall. So to look for posterior wall MI, we have to look for what the reciprocal changes of it in the anterior wall, okay. So we have to look for ST depression in the V1 to V3 leads. Along with that, we will get tall R waves, okay. Next, we talk of the right ventricular wall. The right ventricular wall is obviously supplied by the right coronary artery and does not have a proper lead representation. So the most used leads to see the right ventricular wall will be the V3R and the V4R leads. Along with that, V1 can be a good proxy for visualizing the RV wall, okay. And another small nuance, which is a very famous clinical pointer to know, is that in cases of inferior wall MI, we should always see whether the patient is also bradycardic or not, and from there a lot of management line is also derived. Why is it so? Because in inferior wall MI, we can see in most of the cases the inferior wall is supplied by the right coronary artery, and the right coronary artery is also the one giving off the SA nodal branch. Along with that, in the longer run, it is also giving the AV nodal artery, right? So both of these supply the nodes. So if both of the nodes are being supplied by the right coronary artery and the inferior wall is also being supplied by the right coronary artery, there might be a high probability that the inferior wall has been impacted because of the RCA impaction, and because of that, the SA node and the AV node will also be impacted. So inferior wall MI is often associated with bradycardia, okay. And yeah, this is all that we needed to know about the coronary circulation and their ECG representation at a basic level.